Good evening, delegates, and good evening, speaker. So before starting the session, I would like to give a brief introduction regarding the Shield Connect page. So this is Shield Connect page, which is a knowledge sharing platform regarding women health and gynecology, infertility and pediatric cases. And here there are many blogs written by many doctors related to gynec and OBG. The information you can find here, and the webinar information, upcoming webinars, and the webinars which have been completed and are ongoing. The information regarding that webinars is over here, and our leaders who are our doctors who have been associated with Shield Connect have been listed here. And we have specialized newsletters and awareness programs regarding various conditions we have here. And in various social networking platforms, our Shield Connect is available. Please do watch this one, and I would like to introduce our eminent speaker, Dr. Bindu Priya, MS OBG gold medalist, DNB OBG, consultant urogynecology and OBG, KIMS Hospital, Hyderabad, and she's a laparoscopic and robotic surgeon. And ma'am is going to explain about cervical cancer prevention and HPV vaccination in females. So I would like to welcome Dr. Bindu Priya madam, and I would hand over this session to her to start her webinar.
Yeah, thank you, Dr. Monica, for that kind introduction. So, are we good to go? Am I audible and visible?
Yes, ma'am, you are visible and audible.
Okay. So, I'll go ahead and do the screen share.
Yes.
Okay. I think the PPT is also visible, right?
Yes, ma'am, it is visible.
Okay. So, shall we wait for 2-3 minutes and then start, or?
No, we can start, ma'am. It is live.
Okay. So, thank you, Shield Connect, for this wonderful webinar this evening. So, my name is Dr. Bindu Priya. I'm a consultant gynae and urogynae from KIMS Hospital, Hyderabad. So, this evening we will be discussing about the cervical cancer prevention and HPV vaccination in females. Incidentally, September month is also observed as Gynecological Cancer Awareness Month. And let us see from our side what can we do to help our women regarding the cervical cancer. So coming to the global burden of the disease. So how severe is the cervical cancer? So we all know that globally life expectancy is on the increase, especially in females. So as the life expectancy increases, we also expect age-related gynecological cancers to be also on the rising trend. So worldwide, around 19% of 5.1 million estimated new cancer cases are related to these cancer deaths worldwide. So the studies have also showed that every 2 minutes a woman is dying of cervical cancer. So that roughly approximates around 8 lakh new cases of cervical cancer every year. And we all know where this burden is coming from, since basically this disease is from the low and middle income countries, and India is also a major contributor to these figures. And the most important thing is these deaths are all premature, and definitely they're all preventable. So this is the diagram which is showing, like, the incidence of cervical cancer. And if you see in this list, so almost cervical cancer comes like fourth place in related to cancer in the females. So coming to the disease burden in India, so both in terms of new cervical cancers as well as in terms of related deaths due to cervical cancer, almost India is sharing about 27% of the cases worldwide. So in terms of, as I said, both the new cases that are being detected annually, as well as the deaths that are happening because of this cervical cancer, almost like 1/4 burden is from the India. And coming to the pathogenesis of cervical cancer, we all know that human papilloma virus, that is HPV virus. So in almost 99.7% of cases, HPV is a necessary cause for cervical cancer. So even in this HPV, there are certain high risk and low risk types. So low risk types are basically the 6 and 11. So wherein they are responsible for anogenital warts. In the high risk types, basically HPV 16 and 18, they are responsible for most of the cervical cancers. Not only cervical cancers, but also other anogenital cancers, oropharyngeal cancers, and also in males, the penile cancers are also caused by this human papilloma virus. And this human papilloma virus, depending on their oncogenic potential, they are basically classified into low risk types, intermediate risk types, and high potential HPVs. So we all know that low risk HPVs, they are mostly they don't give rise to malignancies. They are responsible for this anogenital warts, whereas the high risk ones are the ones which are leading to this malignant or neoplastic transformations. The oncogenic potential of these intermediate high risk HPVs, it is quite debatable whether the infection with these strains, that is 31, 33, whether this is going to lead to malignancy or not is still not yet clear. And what are the routes of transmission of HPV? So HPV, if you see, this is the most common sexually transmitted infection in females. And mostly the route of transmission is through sexual intercourse. That's the reason we have to stress on the appropriate sexual behavior in women. And rarely this also can be spread through vertical transmission, that is mother to child, and also direct, like, through the fomites also. Sometimes these cases have been reported. And studies have also shown that in every 10 women, around 8 women, they would have had this HPV infection at any time in their life. So in 10 sexually active women, if we take, 8 of them would have been infected with this HPV infection at any time during their lifetime. And what is the natural history of HPV infection? So if you see the natural history of HPV infection in an immunocompetent women, so most of these infections can be cleared from our system if our immune system is effective. But in few cases, like, in cases of persistent HPV infection and maybe with other risk factors, then the spectrum can change from cervical lesions to pre-cancerous lesions, and from there to invasive cancer. This whole spectrum from HPV infection to invasive cancer, it gives us a window period of around 15-20 years. So this whole 15-20 years is there in our hands, wherein we can identify the lesions at an early stage and prevent the cancers into progressing to an invasive stage. So this slide is also showing the same thing. So normal cervix, and once it gets infected with HPV, so and once if it is progressing, that is where precancer and cancer can happen. But anyways, if it is on the regression side, then as I said, if our immune system is competent enough, then probably these lesions also can be resolved. Only HPV alone sometimes is not, that is not the only factor giving rise to, because not all women infected with HPV, they're going to develop the cervical cancer. Sometimes there are other cofactors that are also responsible for this progression. So like studies have shown that long-term use of oral contraceptive pills, and then early initiation of sexual activity, sexual promiscuity, like with multiple sex partners, multiparity is also like one of the risk factor. Tobacco smoking, both active and passive smoking, has been implicated. And then if the woman is infected with other sexually transmitted diseases, then in case of low socioeconomic status where the nutritional deficiencies are there. So these are all the cofactors which can lead to HPV infection into a malignant stage. And coming to the cancer prevention. So in terms of cancer prevention, there are basically 3 kinds of strategies that for any cancer that we need to follow. First one is the primary prevention, the secondary prevention, and tertiary prevention. So what do we mean by primary prevention is wherein we are looking at the root cause of the disease. So we are trying to modify the risk factors. In secondary prevention, we are like mostly focusing on the screening strategies. And in tertiary prevention is like once the disease has been diagnosed, then what are the treatment options available? Similarly, in cervical cancer, if you see, cervical cancer is very much a preventable disease for the reason that there is effective vaccination strategies are available. Screening strategies are also like standardized worldwide. And then as we have already discussed, there is a long natural history in this disease process itself. That is around 15-20 years of time we have in our hands. And cervix is an easily accessible organ, unlike like colonoscopy or endoscopy, wherein they are like more invasive tests. Cervix is like easily accessible, and hence it is very much pertinent to screen the cervical cancer, and definitely cervical cancer is a very much preventable disease. And this table summarizes the preventive strategies. So as already discussed, primary prevention is wherein we are focusing on HPV vaccination as well as sexual education in the teenage girls and boys. Secondary prevention applies to the screening techniques that we have, that is our pap smear and HPV testing. Tertiary prevention is like once the woman is diagnosed with cancer, what are the treatment options that we can offer her. Coming to cervical cancer screening techniques. So what are the screening techniques currently approved and available for cervical cancer? So we all know that pap smear test, that is cervical cytology screening, that is the age-old gold standard test. And recently there is also like HPV testing. And in low resource countries, especially in countries like India, so WHO has also recommended visual inspection methods, like visual inspection with acetic acid and visual inspection with lugal iodine. They're also available. Coming to the pap smear, so basically we all know that pap smear is nothing but sampling of the cervical cells. So, and the types of pap smear, if you see also, so it can be either a conventional method wherein during our training where we have seen, so we need to collect the cells with the help of a spatula and then put it on a slide and then add a fixative, and then that slide will be studied for these abnormal cells. Nowadays, so we are mostly using this liquid-based cytology. In liquid-based cytology, wherein we just put a small brush kind of thing and then collect the cells. The advantages of liquid-based cytology is that these unsatisfactory smears, and then if it is contaminated with inflammatory cells or blood cells, and then those can obscure the abnormal cells. So those kind of problems can be overcome with the help of liquid-based cytology. But the disadvantage is that it is more expensive compared to a conventional pap smear. And also LBCs, they also take less time to interpret, and that with that same material can be used for other things also, like testing for high risk HPV, and also screening the woman for other sexually transmitted diseases also possible with the same fluid that we take for LBC. And the significance of pap smear, as we already discussed, so it can detect both precancerous as well as the invasive cancer lesions. And whenever there is a positive screening, then probably depending on the result, then we have to counsel the woman for further things. And if the pap smear screening is effectively utilized, and then like like in Western countries wherein they have regular standardized screening protocol, so they have shown that the cervical cancer disease burden definitely comes down. And then so mortality reduces by 20 to 60%. Both morbidity and mortality can be decreased if we can make use of this pap smear screening techniques effectively. And coming to HPV testing. So recently in developed countries, so HPV testing is also like one of the primary screening tests in high resource settings that is used for cervical cancer prevention. Basically, this is also something like an LBC testing kit wherein we collect the sample from the vaginal or cervical samples, and that material is being tested for this high risk HPV DNA types. And mostly this HPV testing, all the studies, they are showing that it should be done for women over the age of 30 years. The sole reason being less than 30 years, sometimes in the HPV testing, there can be a positive result. But as we already discussed that if the immune system is competent enough, most of these women, they will be able to overcome this infection, and they can naturally clear this HPV from their body system. So that is the reason. So if you are detecting it in the less than 30 years of age, sometimes unnecessary anxiety and unnecessary treatments can be given. So that's the reason all the guidelines are recommending this HPV testing above the age of 30 years. But it is also very important to see that when we are doing this HPV testing, we need to use a standardized and clinically validated HPV testing that only can be used for the screening programs. And in HPV testing, also we have this qualitative as well as quantitative analysis. So wherein apart from not only like HPV, whether it is positive or not, what kind of HPV strain is also being detected, that amount of information also we can get from these tests. And now, what are these visual screening methods? We know that it can be done with the help of acetic acid or lugal iodine. So, and this is mostly like, confined to the low resource settings, especially in countries like India. So, wherein this pap smear and HPV screening is not available everywhere. So that is where the WHO has endorsed this visual inspection with acetic acid, wherein a dilute acetic acid solution, that is 3 to 5% of acetic acid, is applied onto the cervix. And then after 1 minute, we have to look for any acetobite areas. But mostly this test is appropriate in women less than 50 years of age, wherein the entire squamocolumnar junction is visible. In menopausal women, what happens is the transformation zone is taken up inside. So, and the entire squamocolumnar junction might not be visible, and in such cases, this might not be very appropriate. And the positive result would be like any acetobite changes that are persistent, that is like less than 1 minute. Sometimes any inflammation, those kind of lesions also can give rise to acetobite area. So that's the reason persistent acetobite changes, that is like more than 1 minute, they are more likely to be either pre-cancer or cancerous changes. And if there are no any persistent acetobite changes, probably that is a negative result. In the case of a positive result, then again, depending on what kind of lesion that we are seeing, probably we have to investigate the woman further. So this is the slide showing the different types of acetobite areas, like in CAN1, how it is, and then CAN2, the dense acetobite areas, and CAN3, apart from the dense acetobite areas, the increased vascularity and reticular pattern. This is more suggestive of CAN3 lesions. So as we already discussed, this VIA, this is all more suitable for low resource settings. And that is the reason our Minister of Health and Family Welfare has included this test as a screening method for women aged 30 to 65 years with a 5-year interval. So in resource poor settings wherein the pap smear facilities are not available, so this is also like one of the approved screening protocol that we can make use of. Coming to the recommendations for routine cervical cancer screening. Now that we know that these are the screening methods that are available to us, so how do we incorporate them in our clinical practice? So there are again different guidelines, like giving different kinds of recommendations. But to just summarize, so younger than 21 years of age, there is no recommendation for screening, irrespective of like whenever they are like they have started their sexual activity. So less than 21 years of age, all the guidelines are saying not to screen the woman. In between 21 to 29 years of age, so we have to go for cervical cytology screening, and the screening interval would be like once in 3 years. And from 30 to 65 years of age, so cervical cytology screening once in 3 years, or co-testing, that is cervical cytology along with HPV testing can be done just to increase the screening duration interval, because this test can be done once in 5 years. And then American societies, sometimes they also suggest only HPV testing, also like once in 5 years is also like one of the screening protocol that they incorporate in their practice. And then older than 65 years, and then most of the guidelines again ask us to stop screening, especially if the woman has no any positive history of any precancerous lesions before. And even for a post-hysterectomized woman also, if there is no any cervical precancerous lesions, the screening can be stopped. And then what about the HPV vaccinated women? So even if the woman is HPV vaccinated, still the screening protocol is the same. So it doesn't depend upon the HPV vaccination status. And now let us look into the primary prevention of cervical cancer. So basically, as already discussed, primary prevention is by implementing an effective vaccination strategy. So to prevent this cervical cancer, we have this HPV vaccination available. So the HPV vaccination, there are worldwide, if you see, so there are around 3 types of vaccines that are available. One is bivalent, which covers the 16 and 18 high-risk types. Quadrivalent, which covers both low-risk and high-risk types, 6, 11, 16, and 18. And there is also 9-valent, that is non-valent vaccine, which covers both high-risk, intermediate risk, and low-risk HPV types. In India, this is still not yet available. So we have only Gardasil, that is the quadrivalent vaccine, and Cervarix, that is the bivalent vaccine currently available to us. And what is the HPV vaccination timing? So what is the ideal age group for this HPV vaccine? So it is basically the children and adolescent age group. In between 9 to 14 years is the ideal age, because if you are giving this vaccination in less than 15 years of age, only 2 doses would be sufficient. And 2 doses given around 6 months apart is the standard protocol for this. And suppose if you're giving it, suppose if that age group has been missed, the next target that we can look for is 15 to 26 years of age. So in this, as I said, above 15 years of age, 3 doses are recommended. And this quadrivalent vaccine, if you're giving, so it is given at a duration of 0, 2, and 6 months. And beyond 27 years, that is from 27 to 45 years, still should we give this HPV vaccination? Again, it depends on a case to case basis, probably because the woman already, the woman is sexually active, she would have already been exposed to this HPV infection, but it is not sure whether she is already exposed to all the vaccine strains that is there available. Suppose in monovalent vaccine, if you take, there are almost like 9 vaccine strains. In quadrivalent, there are 4 vaccine strains that are available. So we are not sure whether the woman would have been exposed to all those vaccine types. So still, if finances is not a very big consideration, then probably we can go for the vaccination even in this age group. And suppose what, like if the woman has taken 1 dose and then she has conceived, so what do we do? So pregnancy, of course, the vaccine is not recommended. And suppose accidentally, like she takes the vaccine and then she has pregnancy has been detected, still there is no any teratogenic risk with this vaccine, but then we have to withhold the further doses in the pregnancy. And once she delivers, then probably we can resume her vaccination course. Breastfeeding mothers also, the vaccination can be given. And even immunocompromised women also, the vaccine can be given, but depending on but we don't know like the immunogenicity that they kind of produce in immunocompromised state, but still it is not a contraindication for vaccine. And booster vaccine, is there any role for booster vaccine? Currently, the evidence shows that there is no any indication for a booster vaccine. And what if the woman has taken like 1 dose and she has missed her second and third dose? And there is no need to restart the entire series. Like even if there is a case of delay with the second and third dose, we can just proceed with the, as and when they report to us, we can proceed with the further doses. And we have to make sure that this series is getting completed at least over a period of 1 to 2 years. And how safe is this HPV vaccine? So safety data for all 3 HPV vaccines, they are reassuring. There are no any serious adverse effects with this HPV vaccine. Since 2006, around 270 million doses of HPV vaccines have been administered, and studies have shown that there are no any serious or major adverse events. So, but in case of any allergic or anaphylactic reaction, then probably further doses we cannot be giving them. And most commonly, the syncope and local site reactions are the commonest things that people have reported with this vaccine. And how efficacious is this vaccine? So definitely this vaccine is quite efficacious because there is around 99% efficacy when administered in the correct age group. So that is for the teenage girls who have not been exposed to sexual activity. So that age group, if we can target and if we can give them the HPV vaccination, definitely studies have shown that it's around 99% efficacious. And also once this quadrivalent vaccine has been introduced in the year 2006, and once you look at the data from 2006 to 2014, definitely the prevalence of vaccine type HPV infection has decreased from 71% in the women in the 14 to 19 years age group. In the teenage group, definitely the infection rate has been decreased from 71%. Also, in the countries wherein there is a high HPV vaccine coverage, there is also a marked reduction in the genital warts also has been observed. So definitely all this proves that the vaccine is quite efficacious if we can use it effectively. And what about our Indian scenario? So though HPV vaccine is not yet included in the national immunization status, but government is taking several efforts towards this program. So like in Sikkim, they have started the statewide program of HPV vaccination, and also in Punjab and Delhi, there are ongoing programs trying to cover girls with this HPV vaccination. And there is also recently, all over in the media, we have seen that Indian HPV vaccine is going to be soon available. So it is manufactured by Serum Institute of India in the name of Cervical. So I think the trials and all has been completed, and there's also obtained the DCGA approval for market authorization. And the main benefit of the Cervical would be like I would say the game changer in HPV vaccination is because it is quite inexpensive. So if you see the current vaccines that are available, the main limiting factor is their cost. So that is the reason probably government is not able to incorporate into our national immunization program. But if you look at this Cervical, it is quite cheap. So probably around 200, 300 per vial is what they're planning for this vaccine. So once it gets rolled out, I think definitely the HPV vaccination coverage will be much more wider, and it is going to reach the general public as well. So just to summarize, so from our side, what are the efforts that we can take to curb this global burden of cervical cancer is probably we have to educate the women regarding their lifestyle changes, and then social changes wherein avoiding early marriages, and then sexual promiscuity, giving the sexual education to our teenagers, and then asking them to use barrier contraception to avoid STDs and other HPV infections. And along with this, so to produce a cancer-free society, we also need to stress upon the HPV vaccination. So, because as gynecologists, we routinely see the girls, like, puberty related girls, puberty age girls, we do see in our clinical practice. So, if we can stress upon this HPV vaccination in that age group, definitely this is going to be beneficial. So, in producing a cancer-free society. So, with this, I would like to conclude. So if there are any questions, probably we can take them, Dr. Monica.
Yes, ma'am. We'll see in this page, we have 2 questions. One question is, do women who have been vaccinated against HPV still need to be screened for cervical cancer?
Yes, that is what we have discussed in that screening strategies. So the cervical cancer screening doesn't depend upon the HPV vaccination of the woman. Even though the woman is HPV vaccinated, still the screening protocol should be the same.
Yes, ma'am. And the another question which we have is, how soon after an HPV infection develop into a cervical cancer?
So that is what the natural history of the disease, if you see. So almost there is like 15 to 20 years of time frame, wherein from the actual infection to the cancerous stage, it takes that amount of time, 15-20 years in an immunocompetent women, but maybe in an immunocompromised state, it can be around 5 to 10 years of time.
I have 2 questions.
Right.
So I guess we don't have more questions. So thank you so much, ma'am, for this informative session. And it is really very helpful for many women, many girls who are actually seeing this webinar. And I hope we do more and more webinars regarding this, like this, and in this platform.
Yeah, thank you so much, Dr. Monica. Once again, I thank the Shield Connect app and your platform, for giving us this opportunity to share our insights on this. As I said, this September is observed as Cervical Cancer, Gynecological Cancer Awareness Month. And we are today discussing about this cervical cancer. Hopefully, we'll do our bit for our women.
Yes, ma'am. It's a pleasure to be in this platform.
Thank you.